pulmonary involvement in the autoimmune rheumatic diseases is a common manifestation and the major cause of morbidity and mortality in these patients. Lung involvement can affect multiple levels simultaneously. For example, the lung parenchyma presenting with interstitial lung disease, it can affect the airways presenting with bronchiectasis, for example, in rheumatoid arthritis. It can affect the pleura presenting with pleural effusion, for example, in systemic lupus erythematosus. It can affect the vessels presenting with pulmonary arterial hypertension, which is a main presentation in cases of scleroderma, and it also can affect the respiratory muscles by weakening them and making difficult the process of breathing. In today's presentation, we will focus mostly on the interstitial lung disease as the main manifestation of the autoimmune rheumatic diseases when they involve the lung. We have to say that the prevalence of interstitial lung diseases in autoimmune rheumatic diseases varies a lot. Systemic sclerosis is the autoimmune rheumatic disease with the highest percentage of ILD, with approximately 50% of the patients having ILD, and most of them have ILD at the baseline, so when the diagnosis is met. On the other side, inflammatory myopathies, especially polymyositis, have also a significant prevalence of ILD, with about 70% of patients with myositis developing ILD during the disease course. Well, of course, that patients with autoimmune rheumatic diseases may present respiratory symptoms where dyspnea is the main of these symptoms, but there are around 30% of patients that develop ILD and do not have respiratory symptoms. This ILD can be captured only by the CT scan, and sometimes the damage of the lung is comparable to the damage of the lung in patients that have already symptoms. But, well, how does the autoimmune rheumatic disease damage the lung? Well, actually, there is a combination of pathogenic steps when we consider the loss of the immune tolerance, the autoantibody formation, the innate immunity activation, T-cell mediated injury, well, a lot of fibroblast activation and epithelial injury that are combined with mediators, with cells that have the effect on the lung by promoting inflammation. So what shall we do? Well, of course we can treat patients, but I believe that we should monitor them in order to adapt and to treat them smart. So we monitor patients at 3 different levels. We monitor them clinically, so every worsening of an existing symptom or the onset of a new clinical symptom is a red flag. On the other hand, the oxygen desaturation during the physical activity, for example, the 6-minute walk test, would be considered important toward the progression of the interstitial lung disease. On the other hand, we can monitor through the spirometry test the decline in the forced vital capacity. On spirometry, it is important because it shows the progression of the interstitial lung disease. And on the 3rd level, we monitor through the CT scan, where we can see the appearance or the progression of a fibrotic change on the image that we get from the patient. Significant progression happens in phases, and actually continued significant progression is rare. So, in conclusion, I would like to say that rheumatic lung is common, is often underdiagnosed, and can exist in subclinical form. There is no universally accepted guideline or consensus for screening all autoimmune rheumatic patients with ILD. So, I would like to suggest everybody should think lung as we see patients with autoimmune rheumatic diseases. Think lung, act early, and treat smart.